Welcome to Heart Blocks. In our previous section, we focused on arrhythmias that arose out of the AV junction, either SVT or actual junctional rhythms. In this section, we'll talk about what happens when that portion of the heart isn't functioning properly at all in terms of actually shutting off or delaying. Quick reminder, AV junction is the AV node and the bundle of His as a group. The sinus node, those rhythms I'm actually going to reserve for the advanced arrhythmia group, and that'll be part of that lecture when that comes around. But without delay, let's dive right in. AV blocks, atrioventricular blocks. For those who prefer to visualize the anatomy, here's a picture that I borrowed just to kind of give you an idea of what we talk about. That the AV node is not the AV junction, it's a group of items. So we'll say this, that the AV junction is actually the AV node and the bundle of His. And this, I like this one because it really helps you visualize. And just to make note that, to give you an idea, right through about here, this is the atria, and this is the ventricles. That AV junction has a foot in each door, essentially, but is also the gatekeeper and the only way through, naturally, that you can connect the atria to the ventricles. And it's where the bundle of His splits into two parts with the right and left bundle branch. That's when it no longer becomes the junction, and it winds up being the bundle branches instead. So things that are important concepts to keep in mind here is that delays can happen along any part of the AV junction. It can be just this part of the AV node maybe is broken. It could be all of the AV node, or instead of the AV node, perhaps it's the bundle of His that winds up, dying out or quitting for some reason, and then you're not able to get a full signal through. And that's the hallmark of these AV blocks, is that something somewhere as part of this AV junction is damaged or busted and is causing delays or complete blockages of the electrical impulses trying to get through. If you want to hear the official phrasing for it, it is the atrioventricular block is defined as a delay or interruption in the transmission of an impulse from the atria to the ventricles due to an anatomic or functional impairment in the conduction system. A little boring, but that's the truest way to say what's going on. Now we'll go forward and take a look at what those actually encompass. This list is combined. It includes both the basic arrhythmia and the advanced arrhythmia group. So we'll start first with the basic arrhythmia list of what all's in here. AV blocks include first degree block, which you've got here, and that essentially, quite simply, is when is defined or found by having a PRI that is greater than 0.20. All of a sudden, now you know why we've been measuring it this whole time. That's finally going to start paying off. So, 0.20 seconds without any interruptions. Every P has a QRS, essentially. Now, in second degree block, and this is kind of how we abbreviate those: first degree AVB, second degree AVB. Second degree is divided up into two types, the Mobitz type and the Winky-Bach type. Now I'm going to go back a slide real quick and if you notice, you've got Winky-Bach written here at the top and Mobitz off to the side. Just has to do with the gentleman who did a lot of the figuring out. Don't focus on that. Modern terminology simply notes both of them as being Mobitz, but divide them up as being type 1 and type 2. And that's what I want you to focus on, is type 1, type 2. The overall defining characteristic of second degree AV block is intermittent conduction. An intermittent conduction of the atria to the ventricles. And so what that means is you're going to have more P's than QRS's. Whereas with the first degree block, you're going to have 1 P per QRS. And the simplest way I like to help people remember these is for Winky-Bach, or for type 1, Winky-Bach's a fun word, and it's usually the first thing you remember. And so type 1 is Winky-Bach. And it has a fun little phrase, which is going, gone. And what that means is that the PRI increases with each successive beat until there's a dropped beat. And I'll walk through this stuff in more detail. I'm just giving you the high view right now. As for second degree, type 2, what makes this one unique is that the PRI is constant. And that really is the only difference between type 1 and type 2. Type 2, the PRI is always the same. Type 1, the PRI increases, it gets longer. Finally, third degree block. In a couple different ways people say this. They can either say third degree AVB or call it complete heart block. Both are acceptable. What happens in this situation is that there is no conduction. Essentially, anything happening in the atria is completely blocked from making its way into the ventricles. And so none of the P's, you may have P waves, but they're not doing anything. They have no value because they're not communicating with the rest of the heart. And that pretty much wraps up what we're going to talk about with basic arrhythmia. The rest of this will be in the advanced arrhythmia section. The AV junction is comprised of the following anatomical parts. I've gone over this a couple different times, so there's a few different locations you can look, but your choices are the left anterior fascicle, which is part of the left bundle branch. You have the right bundle branch. Of course, there's the AV node itself, there's the bundle of His, and then there's the Mobitz portion. And hopefully that one threw you off completely and you just tossed it out altogether. But we're really looking at, the AV node and the bundle of His make up the AV junction. Which of the following statements about AV blocks are correct? We'll just go through these one by one. First degree AV block will occasionally drop a QRS. Nope, we know that's incorrect right away because first degrees never drop a beat. Second degree AVB Type I has a consistently wide PRI with no dropped beats. That's wrong because we know all second degree blocks drop QRSs. That's one of the hallmarks of that. Second degree Type II has a consistent PRI, which is correct, no matter what pattern of dropped beats. So that one is actually correct because second degree Type II has dropped beats with a consistent PRI. Last but not least, third degree AVB has total AV dissociation. That's accurate. Atria and ventricles do not conduct impulses across the AV junction. So on this one, I would say that your third and fourth options, those two are accurate statements. Mechanism of first degree heart block, also known as first degree AVB. The idea is that there is a delayed conduction and only delayed through the AV node or AV junction from the atrium to the ventricle. So the idea is that you have 1p for every QRS, but that delay creates a PRI greater than 0.20. This may be, if it's not the number one thing that we see most common looking at strips, it's got to be the number two. First degree heart blocks are actually very, very common, and they're really easy to spot because it's a simple matter of measurement. The QRS will be perfectly normal. It should conduct without any difficulties whatsoever. You just have a longer PRI. The rules are really simple. In fact, I've already gone over them in the previous slide. First degree heart block. The rate is entirely dependent on the underlying rhythm. You can be bradycardic or tachycardic. Both are completely possible. The regularity, it just depends on the underlying rhythm. If the patient's throwing PACs or something else like that, that's an ectopic beat. It's separate from what we're talking about here. If you, when you see your P waves, they should be upright and uniform. Each P wave will be followed by a QRS, that kind of stuff. The big one is this, that PRI is greater than 0.20, and it's constant and the same every single time. It doesn't get longer or shorter or anything. It's whatever you measure it at, it will be the same every time. And then your QRS is perfectly normal. So, first degree heart block. We'll do our usual stuff, mostly for consistency. All right. Got a heart rate at 80. We see we are nice and regular. Have no pattern and no ectopy. So at that point we can measure the R to R. We'll just go ahead and start with this first one because why not? That comes out to 19. And 1500 divided by 19 is 79. So, perfectly normal. As for our P waves, they are all present. They are upright and uniform. I have 1 P for every QRS, and they appear to be quite regular as well. So we'll say regular. Now, as for the PRI, let's measure on beat number 2. That's actually pretty convenient because it starts on a solid line essentially. And if we measure over to the other side, the PRI actually ends way out here. So that gives us a total of 6. Six times 0.04 gives us 0.24, and that is long. If you wanted the quickest, easiest way to cheat and really save yourself a boatload of time measuring, the simplest way to tell if someone has a first degree block is to simply look at the strip. And I'm going to use beat number 6 as my example, where the P wave starts on a solid line, right? And the PRI ends outside of the space of a large block. Well, a large block is 5 small squares times 0.04 equals 0.20. So at that point, if your PRI is larger than one big box, then it's a first degree block. You don't even have to measure it. You can just eyeball it and say, yep, that's bigger than one large square. At that point, it's a first degree block. Look at beat number 3. You can tell that, this here is the distance of one large square, but my P wave clearly starts outside of that. And so that distance right there tells me it's a first degree block. So without even finishing this, we know we have a long PRI, that it's consistent across the strip, that right there tells us I've got a first degree AVB. Now, to continue on, to remain thorough, we'll look at our QRSs, and those are uniform. We have QRS pattern, and if we measure these out, looks like 2.5. And that is normal. So we have a normal rate, normal P waves, regular, normal QRS, that's basically sinus rhythm with first degree AVB. And that's how we discuss this. If the patient is tachycardic, then it is going to be sinus tach with first degree AVB. If they're slow, sinus bradycardia with first degree AVB. And that's just the language that we use because we need to make note of how fast the rhythm's going. And then when we say first degree AVB, that's communicating that they have a prolonged PRI. So I guess you could say it that way too. Sinus rhythm with prolonged PRI. Now, no one says it that way. Use first degree AV block to describe what's going on, to help describe the measurement that you've taken. Why is it important? Why do we pay attention to the AVB? Well, we go to all this work measuring, so you might as well take credit for the work you did, right? That's one part, but that's not the reason. Why we pay attention to this is it's not normal. You aren't born with it. That's not how your heart is supposed to function, so therefore we should make note that it exists. The reasons or the times that it really matters is that if it's a new onset or if that number's getting worse, if it starts out as being, just a little bit over, maybe like a 0.24, and then later on in the shift or a day or two later it winds up being 0.38, that's a massive change. It's gotten a lot longer. That's a sign that things are getting worse. Most folks really have this and there's not much treatment to do. They're asymptomatic. We just, hey, that's you plus first degree block. But we keep an eye on it all the same. Now, aging, it is part of the aging process. Your heart doesn't get healthier as you get older. It can only wear down. Ischemia is a good one. Vagal tone, if someone does vagal stimulation, it can make that worse. Medications that affect the AV node can be part of that, or the AV junction. And then if you got a stretched out heart, or if you've just had heart surgery, those are different things that can cause this to flare up. Overall, first degree block is only serious if it's new or is getting worse. I've alluded to it already, but I wanted to give you guys a visualization of what I'm talking about when I say blocked P waves or dropped QRSs. Now, this is something that occurs in your second degree blocks and your third degree blocks. And that's the idea. And of course, this little text box here explains it a little bit. But if you look here, you've got a normal PQRS. That's just the way it's supposed to look. But then you see all of a sudden you have a P wave and then you're missing your QRS right here. And that's what we're talking about, is that this P wave was blocked from conducting, and so you wind up dropping a QRS. And so that's just the overall concept. And so you can see in this one you actually have 3 blocked P waves in a row, which causes 3 QRSs to be dropped. And we kind of use that language interchangeably when we're talking about these things. And for those who are curious, this one here is a second degree AVB Type II. And the reason this one is a Type II is because the PRI is the same every single time. You just have a series of beats that fell through. So, as we move forward from first degree blocks into second degree and third degree, I wanted to give you a quick introduction just to walk through the overall concepts. And so this isn't as much about the interpretation as what you see on the screen. I want you to know what I mean when I say dropped QRS or blocked P waves, things of that nature. And the other important thing that goes with this is that we're going to focus more now going forward on atrial and ventricular rates, because we're going to have to start looking at those two separately, especially when we run into blocks like this. So what you see here is an irregular rhythm that you've got P waves with no QRS, and that's what we call blocked P waves, or we note them as having a dropped QRS complex. So the P wave happened, but then it dropped the QRS. It just never happened. And that's the language and the idea behind it. Interpretation-wise, we'll use this as a quick way to just kind of show you a few things. So we'll start by measuring we'll do it the way we always do. What's our overall rate? Well, we've got 1, 2, 3, 4, 5. But I'm also going to mark out our P waves as well and say that I've got 1, 2, and so now we can do a few different things. I'm actually going to get our measurements on here as well that we have from P to P. This is 19. And because we have the dropped ones, it's always a good idea to see, does that maintain, or is there something else going on? And so we'll measure from the start of this one to this one over here, and basically wind up with 19 again, and so on and so forth. If you went through and did all of these, they all come out to 19. It's actually completely perfect every time. So we've measured out the P to P's on that, and that comes out to 19 for sure. As for the R to R, that's exactly the same as well, which it should be for a perfectly regular rhythm, correct? We've got those in place, and so now we can do just a quick bit of our math, and we can say that the atrial rate is 1500 divided by 19, which comes out to about 79, whereas your ventricular is, well, we have that large gap, and the ventricular is irregular, so I have to use 5 times 10 to get a rate of 50. Notably different, correct? As for regularity, this is pretty straightforward. No ectopy, no pattern. But we can say that there are more P's than QRS's, correct? If we do for our P waves, we've already walked through this. They're upright. They're regular. I've got more P's than QRS's. In fact, I've got 3 blocked P waves, but the P waves are regular. As for the PRI, to measure that out, we will go ahead and use beat number 3 and 4. Those should work out pretty well, because beat number 4 has a PRI that starts on a solid line and essentially ends on one. And that's perfectly normal, because I measured that at 4 small boxes. So that's good. As for the QRS, that's uniform when they happen. They've got a tiny little Q wave, a tiny little S, and I will say that I have 3 dropped QRS waves. And those dropped ones are, of course, right here, and right here. The QRS width, just measure that real fast. Pretty easy on beat number 3. Comes out to 2. Yeah, I overmeasured a little. It looks like it's right at 2. That gives us 2 times 0.04. And that's normal. For all intents and purposes, I have a normal atrial rate, but I have a bradycardic ventricle rate. I have normal P waves, but some are dropped. I have a normal PRI. Sorry, I have normal P waves that are blocked, normal PRI. My QRS is normal, except I have 3 dropped QRS complexes. And what we wind up calling this one is sinus bradycardia. Sorry. Actually, what we truly call it, we don't even need the sinus bradycardia, sinus tachycardia, any of that. That's kind of assumed in there that this is going to be slow, particularly when you have a block along this line. Really, all we need to say is that we have a second degree type 2. And that's all it takes. Now, if you go back to double check me, why is it a second degree type 2? Well, it's a second degree because we have blocked P waves or dropped QRSs. The other part that goes with that is the PRIs are consistent. I measured 4 small boxes on beat number 4 here. But if you go through, that PRI is consistent every single time. And that's what gives us a second degree type 2. Mechanism, second degree heart block type 1, also known as second degree AVB type 1. This one, what makes it unique is the fact that it is intermittent atrial conduction to the ventricle. With a first degree block, the P wave will always create a QRS. With second degrees, some of those P waves just don't get conducted through. Now, with type 1, you usually actually see a pretty regular pattern that winds up occurring, something that's pretty predictable. Not always, but oftentimes. What you're looking for in this pattern, or the specific thing you're trying to find, is that your PRI will increase with each successive heartbeat until one P wave is not conducted. When that happens, the pattern resets itself and then repeats it over again. So maybe it's every 4th beat that doesn't go through, or maybe every 6th. It could always be variable, but that's what you're looking at. You're looking at the PRI, measuring it with each one of those beats to see if it gets longer and longer until it drops. And that's where I get that phrase I'd mentioned before, which is going, going, gone. And the block is, of course, right here, and it is intermittent. And so that, yeah, you should have your normal sinus beats, just occasionally some don't go through. Your QRS should be perfectly normal, though. There shouldn't be any problems there. The rules for second degree AVB type 1, your atrial rate should be pretty well normal. It can be from 60 to 100. It may be slower, it may be faster, but most of the times it's right in that normal range. What is important, though, that with a real good second degree type 1, most times your ventricle rate's going to be slow. So these tend to be bradycardic, and that's going to be one of your hints as to what's going on. Not only the dropped beats, but the fact that it's also a slower heart rate. This is definitely going to be irregular for sure. I didn't touch on it with the previous slide, but I'll mention it here. The R to R interval does get shorter as the PRI gets longer, and there's a pattern to that comes out of it, which is where I get the grouped beating mentioned there. But the idea is that the PRI gets longer, so the P wave is closer to the R wave, and that winds up kind of tripping things up a little bit. We'll look at some examples, and hopefully it'll make more sense when you actually see it in action. Your P waves should be perfectly normal, except some of them are not followed, so you're going to have more P waves than QRSs. The PRI should always be greater than 0.12, but I don't really have a top end for that. It just progressively gets longer until one's not conducted, so it's very, very likely that you'll have one of these that's maybe even greater than 0.20, and that's perfectly acceptable. Your QRS, though, should look just normal. There shouldn't be anything crazy going on there. Okay, we'll approach this just like we always do. I've got 1, 2, 3, 4, 5, 6, and it looks like, so 6 times 10 gives us 60. We are definitely irregular. And in fact, there's a large gap between 2 and 3, as well as 6 and whatever that next beat at the end of the strip might wind up being. I have no ectopy, and I may have a pattern though, and we'll investigate that. So we'll do question mark pattern. Now I do happen to have more P waves than I do QRS. I'm actually going to switch colors to help you see those. And we'll start right in the center because that's the easiest one to see, that this is definitely a P wave right here. This is a P wave. This one, and this one, and in fact this one at the very end. And if we work backwards, we'll see that this is a P wave because it's occurring right after the T wave. But if you look at other beats on this strip, you'll notice that it's only on that final one. So like in beat number 6, how that P wave is right next to the T. And so we can actually assume that both of those are P's in that case. So with that, what we need to do is some measurements. So let's see what we get. We'll start with our P wave measurements, and we want to do what we always should. They're upright, they're uniform, but I have more P's than I do QRS's because there is a QRS missing here after beat number 2 and after beat number 6. So we'll say I've got P greater than QRS. And I'll say 2 are blocked. Now, beyond that, we need to check and make sure the P waves are occurring regularly. And so we'll start with with beat number 3, and I'll measure forward and backward. And so if we go forward to about here, that's 19. And if I go back to this one, I'll use dashes through here. That is also 19 small boxes. And if I go back one more to this guy here, that one also measures out to be 19. So I do have regular P waves, or that the P waves are maintaining regularity. Next part is going to be the PRI, so we need to measure that. And we'll start with this first one here, and I'll actually mark this one above. And we'll make that a 4 small boxes. Mark you here and here. And that's going to be 6 small boxes. I'll measure you here and you right about here. And that comes out to 10, 5, 6, 7, 8, 9.5. Yeah, we'll call that one 10. And over here, this one across is going to be 12. And then this P wave has no QRS, and so this one is our drop. So we've established we have the going, going, gone. We've gone to 4, 6, 10, 12, drop. And of course that's small boxes. And we'll call that going, going, gone. Yes, I could do all the calculations and tell you exactly how many seconds or milliseconds that each one of those is, but for what we're doing, just knowing how many small boxes they are, that's the important part. So let's work backwards, and now we'll look at the previous heartbeats that we have on this strip. So we'll look at strip number 1 or beat number 1 and 2. Beat number 1, I can't get a full estimate because that P wave disappears off of the screen. But beat number 2, I can get that PRI, and I will tell you that it is also 12. So what we know for certain is that we have a pattern that 12 small boxes is the final PRI length before you drop a beat, and then you start over 4, 6, 8, 12, drop. And so that we can assume the final beat on the strip, that P wave that we can see to the far right, will likely have a PRI that's only 4 small boxes. That's what we've established there. So knowing that alone, we can look at that and say that's very, very likely a second degree type 1. And we really don't have to do much more than that, technically speaking, but because, you know, we always do a good and thorough job, we have to double check our QRSs just to make sure that they are uniform. They have the they have QRS pattern, and the measurement on those is from about here to here. Let's say that that's 2.5. I measured over on beat number 2. So 2.5 times 0.04 10, which is normal. And so the true answer to this item is to say it's second degree type 1. And that's about all you need to say, is that you've recognized the pattern that's going on. There's no need to say sinus rhythm, sinus brady, sinus tach. Just say second degree type 1, and pretty much everyone will know exactly what you're talking about. And that's all there is on that strip. So why is the second degree AV block type 1 so important to know and understand? Well, it's never normal. You're not supposed to be in that rhythm, so it only occurs in situations where there's something wrong or something's changed about your heart. A heart attack, specifically inferior MI, and that's going to be your right coronary artery is the one that we're looking at there. It's highly likely, especially if this is new onset, that it's due to something like that. That being said, the cause isn't the only thing that we need to look at here. Significance, importance. It could be due to a heart attack. Ultimately, these are unstable by nature, especially for as slow as a heart rate can get, because then with a low heart rate, you wind up, the bradycardia over here, you can wind up with a low cardiac output. And those are things like syncope, they've passed out, maybe have low blood pressure, hypotension, or even just could be dizzy. Things like that. Like, it can go anywhere along that spectrum depending on how bad and for how long this has been occurring. The real danger, especially if it's a new onset, is that it can progress into third degree heart block, which is much worse by far. So we need to be really aware that that's something that can occur. Ultimately, triggers, just to talk about triggers real quick. Ischemia, we talked about that with the MI. Cardiomyopathy, which is a enlarged heart. High potassium, hyperkalemia. So that's why we check those labs and we correct those when we can, or when it needs to be done. Medications, those are always a bit of something that could do it. We're looking at stuff like beta blockers, or cardizem's a good one, amiodarone. Medications we give quite frequently to a lot of our patients. That's why medication management is so important to prevent things like this from happening or getting worse. A high vagal tone, just if your vagus nerve's overstimulated, and hyper and hypothyroid can also be triggers for this type of thing to occur. So treatment. Let's talk about what you can do to help these folks if they do come across. You just follow your ACLS. And so you're actually going to start out with atropine. If that winds up helping, awesome. Dopamine, dobutamine is probably your next best bet to help maintain things. If that's not effective or not effective enough, that patient may need temporary pacing, either through the pads, so the ones that are on their chest, or they may have to get a special procedure done where they can get the temporary pacemaking wire placed. And temp pacer wire. So those are the couple of different things that can go on in those scenarios. And that's why it's important, and that's why we focus and hone in on the fact that when this occurs, what are we doing to help guide treatment and help make sure the patient improves. Second degree AVB Type II. What makes this unique and important? Well, at its core, what it is an intermittent atrial conduction to the ventricle. And so that's why we have this marked here as blocked, but I again want to point out that it's intermittent. And that's because in this scenario, what occurs is you often have a regular pattern or frequency. But with that, by the way, that's not always, but that pattern and all of that kind of stuff, what it really boils down to is that your PRI remains unchanged. And that's the most important part on there, that each PRI is the same, until suddenly a P wave is not conducted, and that goes right back to being exactly the same PRI it was beforehand. And that's what separates this from second degree Type I, where in Type I you get that PRI that gets longer and longer till it drops. This one remains consistent all throughout. And also, you should have a normal QRS conduction. Another way to look at it is that the AV node or AV junction will selectively conduct beats. Once it's in the ventricles, though, things are just dandy. As for the rules for second degree Type II, you're going to be looking at your atrial versus your ventricular rate. The atrial rate should be pretty well normal and not too much going on there. Your ventricular rate will very nearly always be bradycardic. That's kind of the big focus there. As for your regularity, it really just depends on the conduction that's occurring. Sometimes it is perfectly regular, other times it is quite irregular. It just depends on the person or the strip that you're looking at, because people can change throughout a shift. I've definitely seen that more than once in my time. As for your P waves, they're just fine. They're upright, they're uniform, but you will have more P's than QRS's. And if you have a regular pattern, it's really beneficial if you can figure out what your ratios are. It's like, is there 4 P waves for every QRS? Or is it, 3 P waves for every QRS? And that's what we're talking about, is P to QRS ratios. Your PRI, it's going to be greater than 0.10. It's common to see that it's prolonged, greater than 0.20. And that makes sense, right? If first degree block happens because the AV node is not functioning properly, and then second degree block happens because that same AV node, AV junction is functioning even worse, you can kind of stack those two on top of each other and wind up with someone who has a long PRI and is also dropping beats. And we'll talk about the name for that in a little while. And of course your QRS should be just fine. Approaching this like always, we have our marks. It is a 6-second strip. We have 3 QRS's. So because we're obviously talking about second degree blocks, specifically type 2, we're going to look at both the atrial and the ventricular rates. And with the ventric, that is 3 times 10, gives us a heart rate of 30. Whereas with the atrial, well, we'll need to look at that a little closer, won't we? But first, regularity. The 3 beats that we do have on screen actually seem to be pretty regular. So we will say that that is the case. Question mark pattern, because there does seem to be a little something going on there. We don't have any ectopics. But I will say this, we do have more P's than QRS's. And where are those P waves? Let's go ahead and mark those out, shall we? This is definitely a P wave. This is a P. So on. And actually, if you go backward, you'll say that that one is right there. So we have 1, 2, 3, 4, 5, 6. We have 6 P waves. And what is our distance between them? I'm going to go ahead and switch back to red since we're specifically doing P waves. I'll do these way low here and probably about right here. That distance there is 23. Next P wave starts probably about right in the middle of here. That one comes out to be 24. Our next one starts a little wide. I know it is difficult with these simply because the initiation of the P wave's a little bit off on those, but 23, 24, small boxes right in that zone. So we can use that and say 1500 divided by 23 gives us a heart rate of 62. It's not too far off there. As for our ventricular rates, if I measure from this R wave on number 1 all the way to the R wave on number 2, we have a distance of 47. And that gives us a heart rate of 32. Bradycardic for certain. Well, we've established that we have regular P waves. We have more P waves than QRSs. So let's go ahead and finish out what we would normally say, which is that these are indeed upright and uniform. I realize there are some variances with these, but if you'll notice, the isoelectric line also has some variance, and that's likely due to artifact, just a little bit of either motion or muscle related in that regard. We have more P's than QRS's. We are regular. All right, so we know that much. In fact, we can say that 3 of them are blocked. Or sorry, yeah, 3 P's blocked. In fact, every other one. So that is a 2-to-1 ratio of blocked, or if you look at it the other way, that's 1 out of every 2 gets conducted. So either way, the PRI is what we have to do next, so we need to get that measured out. And we'll start right here, and that one goes to about right here or so, and that gives us 6 small boxes. This one here, about right there, and that's another 6. And so probably about right there, and there. 6 again. As for, so that would say 6 times 0.04, 0.24 sec. And so that is long, but it's consistent. In that every single time it's the same length. And so that shows us that, you know, with that pattern, that fits one of those criteria for second degree type 2, is that you have the same PRI every time. We'll look at our QRSs just to make sure we don't overlook them. We can say that the few that we have are uniform with our S pattern. Sorry, those were bugging me a little bit there. Uniform RS pattern, if we measure these out, we can say from here, my J 1, 2.5, 2.5, which is normal as well. So at that point, we can say that we have normal QRS. We are bradycardic, but we do have a pattern of blocked P waves, and to that end, we have 3 dropped QRSs, and those would have been in these 3 locations here. That's where all that is. All that put together tells us that we have second degree type 2, 2-to-1 conduction. And that is the official answer. I'd like to explain further the conduction ratios, or the the 2-to-1 blocks, however you'd like to phrase that. And so this slide and the next slide illustrate exactly what I'm talking about. So for this one here, I'll just go ahead and mark this with a 1. This is a 2-to-1 block, or a 2-to-1 conduction ratio, sorry, where 1 out of 2 is conducted through. If you did all the measurements, you'd be able to tell that the atrial rate here is 90 and that the ventricular rate is actually 45. And that's exactly how this works out. That also makes sense because 90 divided by 2 equals 45, right? So now that you've seen a second degree type 2 2-to-1 conduction, what's next? A 3-to-1. And so this strip here, 3-to-1 conduction ratio, you have essentially the same scenario where you've got an atrial rate of 90. However, only 1 out of 3 beats is conducted properly. So you now are taking 90, dividing by 3, and that creates a heart rate of 30, doesn't it? And that makes a lot of sense. I mean, imagine if this patient's heart rate was 60. If 1 out of every 3 beats went through, they'd have a heart rate of 20, And that's that idea, is just being able to say, I've got a second degree block, type 2, with a conduction ratio of 3-to-1. I don't care if their heart rate's 150. If you still divide that by 3, that's not a great heart rate. So mentioning that conduction ratio helps a bunch. The next slide to go with that is this here. So we'll just keep going down the line. You've got a 4-to-1 conduction ratio now, where you've got that same atrial rate of 90, but 90 divided by 4, it's a 4, winds up giving you a heart rate of 22. And just take a step back and look at that strip. Even if you did the 1, 2, 3 and took 3 times 10, you still get a rough heart rate of 30. And at that point, they're severely bradycardic. This patient's putting out a quarter of the heartbeats that they're supposed to. That patient needs intervention. That patient needs to be on a drip, on some kind of medication to speed up their heart rate, triatropine. We need to have a pacemaker on them or in them to help prevent this from becoming a bigger problem. So that's, again, illustrating why stating what the conduction ratio is helps explain what's going on pretty vividly. Last but not least, there is that scenario of variable, because this is healthcare and there's always a gray zone. And it is not uncommon for patients to have more than one ratio or conduction ratio occurring. So if we look at this one here with an atrial rate of 90 again, this patient actually is bouncing between a 2-to-1, so we'll say 2-to-1, and that's what this first section is here. And then this is a 3-to-1, and then right here and here, you're back to a 2-to-1 again. Ultimately, we call this second degree AVB with variable conduction. That's all there is to that. Again, just wanted to let you see how those work. Why is second degree AVB type II important? Well, similarly to type 1, it doesn't happen normally. It's because something is wrong with the heart. Most oftentimes it's due to ischemia. And so what we're looking at is possibly a heart attack is the first thing we assume, especially if this is new onset. Yeah, because anytime it's new, it means something changed. So we always think about a heart attack. If it's a heart attack, it is likely the right coronary artery that's responsible. Regardless of that part, If this second degree block occurs and then begins to worsen, that progression into third degree block is what we're really concerned about. We definitely don't want that to happen. We want to intervene before that occurs. Triggers, like we said just a minute ago, ischemia, so heart attack. Cardiomyopathy, you've got a stretched out heart. Hyperkalemia, you've got high potassium. Medications, you've got your beta blockers. Cardizem can do it. Amiodarone. High vagal tone. So you do the vagus, you have a patient vagal down a little too much. And your thyroid, either up or down, could be a cause. All that being said, what's the clinical picture? What are we looking for? Well, they're going to have an irregular pulse, right? Because there's going to be that odd pattern to things. They may feel palpitations. What we're particularly concerned about is when that heart rate gets low, like much lower than the patient would normally have. You start seeing those symptoms of low cardiac output, like syncope, low blood pressure, and I abbreviate as HOTN, dizzy, short of breath, any of those types of things that you would normally expect with low cardiac output due to a drop in the heart rate. What do we treat with? Well, we treat with ACLS is the big one, the bradycardia pathway, to where you've actually going to treat with atropine if you can get it in quickly enough. If you can't, there's always temporary pacing, either with pads, or if you're at the hospital and can manage to, you can put in temp pacer and actually thread one in with the patient. And we'll actually talk about that a little bit in the pacemaking section. But those are your treatments. Again, look at the patient, treat the patient, go off of their symptomatics. If drugs work, dopamine or dobutamine are usually good choices to help get that heart rate back up and the blood pressure. Your patient started the shift in rhythm A. Later, the alarm sound and you see rhythm B. What action would be most appropriate? And so just looking at these, they're starting off in what appears to be a nice clean sinus rhythm, but then here it looks like we have a second degree block, and that's going to cause bradycardia. So you have a patient with a new onset bradycardic rhythm. How scary is this, particularly that it's a block? It's not a false alarm, because we know that. Would we have the CNA evaluate a patient after a rhythm change like this? No, we wouldn't. So this really comes down to, do we call an RRT? Do we just notify the primary nurse? Or, do we contact that nurse immediately and escalate if unable to contact? In this case, because this rhythm has such a potential to get very bad very quickly, I'm going to say that it's the emergent contact of that primary nurse, and definitely escalate if unable to reach them. The telemetry tech notifies you your patient has been in sinus rhythm, but is now in second degree AVB Type II with rates of 50 to 60s. So we're bradycardic. What first action would be most appropriate? And so this is a question of your patient has a new rhythm, a slower rhythm. How do you address that? Well, it's not something you're going to delegate to a CNA, so that one's out. Would you call the attending first and have them be the one who looks at the patient? Would you call an RRT? So we have the attending question, or do you call an RRT and have them look first? The answer is essentially no for all of those. You, the primary nurse, needs to be the one who evaluates that patient, then notify the attending. depending on what you see, may determine whether you call an RRT as your second action. That's appropriate. Or emergently notifying the attending. That may be your second action. But the first thing you need to do is be that primary nurse who's evaluating the patient, then calling to let them know what's going on. Complete AV block. Complete heart block, also known as third degree AVB. What's going on? What's the idea? Well, as each of these heart blocks has progressed, they've gotten worse. In first degree, they all made it through. In second degree, some didn't. And when I say get through, atrial impulses. In third degree, none of the impulses make it through. And that's what makes this a complete heart block. Actually change colors here. Totally blocked. Nothing that happens in the atria communicates with the ventricles. And vice versa. Anything in the ventricles won't be conducted backwards either. It's a total, they've been completely severed. And the different ways we explain this or express this is that the atria are electrically independent. They've been cut off. The P waves will actually look pretty awesome. They should be occurring nice and regularly without anything special going on. The ventricles, those are now isolated. So if anything happens below those, below the AV junction or below the AV node, it's entirely on them and it's independent of what's coming out with the with the P waves. So if you wind up having QRSs, they have nothing to do with the P waves that may be around them. And I'll show that to you as we go on. In terms of these patients being alive, the only, truly, when a patient's in third degree block, it is an escape rhythm that keeps them alive. That's not the focus of basic arrhythmia. That will be the focus in advanced arrhythmia, how to identify which type they are. For today, just realize that, there is an escape rhythm present, and that's what's keeping them going. What are the rules for third degree AV block or complete heart block? Or there's a couple different things that we wind up calling it. I'll usually call it third degree most of the time, because there's about only one thing that we really talk about, at least without being in a burn unit. It's about the only time we talk about third degrees. Anyhow, what you're going to see is this. The atria are going to be clipping along at a nice normal rate. There really shouldn't be anything too exciting going on in terms of the number of P waves and the rate that they're moving. But what you will see is this. The ventricular rate, the QRSs that you can identify and count, that's definitely going to be bradycardic. On rare occasions, it might actually be a normal rate, but that doesn't happen all that often, at least in my experience. What you're really looking for is this, that you have very regular rhythm, very, very regular. It's going to look uncanny, actually. But the P waves and QRSs are going to be separate from one another. And here's what I mean by that. It's that you're going to have more P waves than QRS, right? Yeah, more P waves and QRSs. They're going to be upright and uniform, and that's cool. The PRI is what's really going to clue you in as to what's going on. When we talked about first degree block, the PRI was longer. When we talked about second degree blocks, the PRI either changed or was really consistent, right? There was a pattern to it, or it's stayed the same. In a third degree block, it is just, it's nuts. You can have one that's only 4 small boxes, and then 12 small boxes, and then 6 small boxes. Like it's just up, down, left and right. It's never the same thing twice in a row. And that's one of those clues that you have. The other clue is that the P waves can be hidden in the QRS and T waves. And that's another thing that makes these very challenging to identify, because if you're not able to find all your P waves, you'll never be able to either properly measure the PRI or realize that you're in a 3rd degree block. And so we'll take some time to focus on that part as well. Ultimately, the QRS can be normal or it can be wide, just depends on the scenario. Don't let that throw you off today. All right, the math work on this is a little more intense, probably one of the more challenging ones that we've come across so far in the lectures. So please be patient. There's a lot of marking that needs to be done on the screen. This is really much easier done in real life when you've got a set of calipers, but hopefully this will show you what you need to do. And it is a 6-second strip. I am going to go ahead and mark out the P waves that I know. Like that. And so overall, I've got, we'll do atrial and our ventricular rates. Let's see, ventric is going to be 3 times 10 gives you 30. We are definitely regular. I don't see a pattern offhand, and I don't have any ectopy, but I do have more P's than QRS. Atrial rate, I would count 1, 2, 3, 4, 5, 6, 7. So I've got an atrial rate of 7 times 10, which is going to be around 70. But since we're nice and regular, let's go ahead and get some measurements. Plus, I want to know what the P to P is anyhow, so that I can figure out the regularity on that. So we'll start out with the QRS. And that, we'll just do between 1 and 2. Between here and here. Just going to use a dashed line. Is 49. 49, I kid you not. So 1500 by 49 gives us an exact heart rate of 30. So obviously bradycardic. That part's done. Next part, atrial. Let's figure out what we have here. So I'll measure from the start of this first one to the start of the second one. And that comes out to be about 19. And I'm going to go ahead and do some dashed lines across here to the next one. And that comes out to 18 or so. Not perfect. And then I'll mark this next one. And that comes out to about 15, right between 18 and 19, right around there. So overall, the P to P distance is good. And just by doing this, if you take a moment and realize that we're actually missing a P wave. From that first P wave that I marked, if you actually go back 19 spots, that is going to place you right about, let's see, this would be 5, 10, 15, 19. Right here is where there should be a missing P wave at. So I actually have one more P wave on there than I realized, which makes a lot more sense now, because 1500 divided by 19 equals 79. And then if I add one more P wave, all of a sudden we have 80. And so we have a normal atrial rate that is really regular, but then we have a bradycardic ventricular rate. We've marked out our P's, So let's analyze those a little closer. They are upright and uniform. I have more P's than I have QRS's. It is regular, but I don't quite have a pattern yet. I'm definitely feeling like the P waves are being blocked though. So let's take a look at those PRIs, see what we can figure out. And I'm actually going to change back to red for that. And so the PRI here to here is right at about 9. And if I look at my next one, from here to here, that's a 3. And those are the only two I can measure. It's a 9, and then it's a 3. But what do we know? We know that we have a hidden P wave right in the middle of a QRS, and that's a huge clue that when a QRS just completely steps right on top of the P wave like it doesn't exist, that's a big clue that we're dealing with a third degree block. Additionally, you'll notice that there's, 2 open P waves here, but then we manage to have 3 P waves, a QRS, and then we're back in the open again. There's just really no rhyme or reason. It's like the P waves are happening and then the QRSs are occurring separate of those, and they're really just not matching up very well at all. So to that end, I would say my PRI is 3 and 9 small boxes, and then we have no pattern, no reset. And in case you were curious, which is normal, but 9 times 0.04 gives you 0.36, which is definitely not normal. As for the 3 QRSs that we have, they are uniform. They have a small QRS pattern, and they measure out to be about 2.5. Normal. They're actually narrow, which is good to know for the future. Ultimately, this meets all the requirements that we need to say that this is a third degree heart block. Okay, more third degree heart block, and we'll do just like we have been before. And this again is a 6-second strip. We're going to be looking at both the atria and the ventricles. It is nice and regular. There's no pattern that we can really see, and there's no ectopic beats either. Other things that we need to think about, so let's see if there's just 2 on the screen. That ventricular rate's pretty easy. But because it is regular, we can measure between them. And so from about here to here, all the way across, is right at around 61 small boxes. And that will give us a heart rate of 24 and a half, so 25, which is most definitely bradycardic. Now, we do have more P waves than we do QRSs, So let's take a look at those a little closer. I'm going to switch into red again, and we'll just go ahead and mark these. And that's a P wave. P waves there. We will mark out their regularity, see what we can figure out. And we'll just go ahead and do this second one to this one here. And that distance there is right at 19. And so yeah, if we take that and do 1500 divided by 19 gives us about 79. And that's kind of interesting, right? Because actually if we count these out, we've got 1, 2, 3, 4, 5, 6, 7. I only count 7 P waves, but I have a calculated rate of 79, and if I look closer, I'll notice that right around this spot on the right hand side, I'm missing a P wave. And if I look closely at that T wave, I'll notice that it has a bit of an irregular shape. So what I can do is I can either start at this one and measure forward, or I can start at this one and measure backward. And ultimately what I'm looking for is 19 spots, correct? So let's see, that's 5, 10, 15, 16, 17, 18, 19. Counting back by 19, this right here is actually my P wave. And that's my missing one that I was looking for. And that brings me up to 80, and that also tells me a few things, that the T waves are walking right over my P waves. It's good information to have. So let's go ahead and do the P wave analysis and say that they are upright, regular. I've got more P's than QRS's. They are regular, and so I'm probably dealing with a block of some kind. We know that. Let's go ahead and try and figure out the QRS, or not the QRS, the PRI. Well, if I was going to measure this one here, that's almost kind of impossible because the P wave and the QRS fall on top of each other. So maybe that's 2.5, but I don't think that's accurate. And even if I pretend and say that that P wave is not the one that caused that QRS, that means I'd have to use this one over here, which would be 19 plus another 2.5. That would be 21.5 for my PRI, which is well outside of anything that should normally occur. Now, if I look at my second beat that I do have on the screen, we've got, probably say about right to here or so. And that gives me an 8, which is, potentially real, but you've got either a massive one or one that's too short, followed by one that's still really long and not quite normal. And none of these really line up. They don't create a pattern like we look for. So what I could really just boil this down to is say wildly inconsistent. And because they're wildly inconsistent, there's no pattern, no reset with the dropped beats. As for our QRS, the two that we have, they seem to be uniform. They have RS for the pattern. And so let's go ahead and try and measure the QRS on these. So I'm going to actually do some erasing here, just so we can get a better look at it, and say that the J point appears to be about right here. And right there. What do we get? 1, 2, 3. So I get right at 3 small boxes for my measurement there. And if I go over to this other side, I get actually 2.5 as well. So between 2.5 and 3 small boxes, both essentially the same. We'll take the 3, which is still normal. It is narrow, technically speaking. So at that point, I think we've met all the criteria we need for third degree, correct? That we've got a reasonably normal rate for our atrial part, the P waves, definite bradycardic rate for the ventricle. The P waves and PRIs are wildly inconsistent. There's no pattern, the multitude of things that we've talked about already. So this is a great example of what third degree block looks like. Why is third degree heart block important? Why third degree AVB? Well, honestly, because it's one of the deadly rhythms, one of the deadly arrhythmias. If you really think about it, this patient's heart, the top and the bottom half, are completely separated from one another, dissociated. They're not communicating electrically. That means that this patient is in for a rough time unless they're very, very lucky. The things that come out of this are, why is it important? Well, acute heart attack, acute myocardial infarction, acute coronary syndrome, whichever one of these you want to go with, that's an upset heart, especially if it's new onset. Usually they're going to present with syncope because all of a sudden they go from a heart rate of 60 to 80 down to a heart rate of 40 to 20. It's so fast and drops so precipitously that it's a pass out that winds up bringing them in. If they're lucky, they wind up with a heart rate. Sometimes it just might be that, that fun statistic where a large majority of people pass away with their very first heart attack. Things like this are the reason why. If they are fortunate enough to have a good escape rhythm to keep them going, you still have the risk of exacerbating an underlying problem. Because let's be honest, if you're to the point where you have this type of heart issue, you probably have multiple comorbidities. So it can take a bad situation and make it worse. So what does it present like? What does it look like? Well, they're going to have that irregular, well, it actually shouldn't be an irregular pulse. It should be perfectly regular if they have an escape rhythm. Ultimately, it's the bradycardia that we care about because of that low cardiac output. The syncope, like I mentioned, the low blood pressure, the shortness of breath that can come with it, this low BP is the one that we're really worried about. We can have change in level of consciousness. Treatments, well, depends on if they're truly unstable, which they will likely be. You're going to follow ACLS. You're going to give them atropine. Atropine will probably not work at all. So be ready because temp pacing with pads is going to be your first go-to to help keep them alive. And then probably transition into either a temp pacing wire or a permanent pacemaker, depending on their problem. We can definitely try medications in the meantime to help bridge the gap. That's perfectly appropriate. We just have to see what winds up working out in their favor. Ultimately, what's going to cause this? Well, ischemia, we talked about that. Cardiomyopathy, enlarged heart, hyperkalemia, elevated K+. Meds, same as before, anything that would cause a severe bradycardia. So that can be your beta blockers, cardizem, And you think about it, those are the meds we give for AFib patients that are running too fast, because it helps slow down that AV node and the conduction through them. Well, now what happens when those drugs work too good? Now, none of the conduction could go through, or a very, very small amount. Your high vagal tone is one, and then inflammation of the heart can do it too. Either way, it's that ACLS approach to things that always take third degree serious. That's why we make a big deal about catching it every time. Common presenting heart rates of second degree and third degree heart blocks are bradycardic. What symptoms may be associated with these new onset low heart rates? And so this is a question about symptomatic bradycardia, particularly in second and third degree. And so think about it. Low heart rate is usually a drop in cardiac output. So which of these are symptoms of low cardiac output? Chest pain is absolutely one. Hypotension is almost always one. Decreased level of consciousness, definitely. Shortness of breath can absolutely happen. And anxiety, because they just don't feel good because their heart rate's so low. So on this question, it's actually every single one of these answers is correct. When providing care to patients with third degree AVB, also known as complete heart block, which of the following are priorities? So this is a question of you have a bradycardic patient, and this is one of those potentially lethal arrhythmias. What are you going to do when you care for this patient? You're going to visualize them, absolutely. Go lay eyes on them. You're going to check for a pulse. You're going to collect vital signs, because that's just what you do when you're checking on a patient, right? If their heart rate is so low or they don't have a pulse, you may have to initiate CPR. You also need to confirm whether their DNR, DNI status. That may absolutely change the way we react to that situation. Ambulate to the restroom? Absolutely not. Why would you walk your patient when they're in this bradycardic rhythm with probably low cardiac output? Definitely don't ambulate. Checking level of consciousness? Absolutely, because that's part of visualizing the patient, right? You talk to them. And then move the patient from the floor to the bed immediately. If they happen to have had a syncopal event because of this and passed out, leave them on the floor, keep the scene safe, work on them there. When there's enough help, then you can move them to the bed, but don't make that your first priority. So yeah, ambulation and moving the patient doesn't need to be done right away.